Thank you very much. Yeah, good to see you again. I think it's a huge task for me to talk about recent advances in management of acute stroke within 15 minutes. So, as you know, this is a stroke chain of survival, actually. We start from pre-hospital and then post-hospital. So with the limitation of time, I will be focusing on the acute treatment and mainly focusing on the reperfusion therapy, which are thrombolysis and thrombectomy. So, what are the new information and new trials? As mentioned earlier by previous speakers, that time is brain is a concept, and there are people who are fast progressor and slow progressors. So, how do we define that? How do we find the ones who will respond to our treatment? So talking about reperfusion treatment, now that we have two types of treatment, the first one is thrombolysis, the medical treatment, and the other one is mechanical thrombectomy. So for the thrombolysis, the IV thrombolysis, now we all know that treatment within 4.5 hours is the standard. And Dr. Silaja mentioned earlier about the wake-up stroke and the unknown onset, and the ones beyond 4.5 hours. And now we are facing we have a new medical treatment after a long time. We have tenecteplase that can replace alteplase. I'll be showing you some data on tenecteplase later on. For mechanical thrombectomy, we know that 6-hour window is the standard, and now we have tissue clock extending the time window up to 24 hours. And we are having new concept of large core and treatment beyond 24 hours and also basilar occlusion. So talking about thrombolysis, I just want to use this guideline as a template that we know that 4.5 hours is the standard. And beyond that, or we don't know the onset, unknown onset or wake-up stroke, we need tissue clock, right? Using either perfusion imaging or diffusion flare mismatch or clinical and imaging mismatch would be the key to find persons who will be responsible to the treatment. So for the ones who are coming with wake up, already covered, and these are the two studies, wake up study and extend study, where they use imaging to define patients who will be responsible, who will be responsive to the treatment. Just to focus on the new, not very new medication, tenecteplase. Tenecteplase is another thrombolytic agent that the dose which is generally used is 0.25, and it's more fibrin specific than the alteplase, and circulating half-life and terminal half-life is longer, so you just need to bolus the medication and don't need to drip it over an hour. So it's easier to use, and it has been proven that people who use tenecteplase has less time to prepare, and also better when you need to transfer them to another hospital. So it's been there for a while, and there are so many clinical trials on tenecteplase starting from 2015. And just want to summarize that the studies are using, in the initial studies would be the one using tenecteplase comparing to alteplase or the standard RTPA within 4.5 hours. And the newer ones would be focusing more in the new indications. For example, the mild stroke with LVO, since tenecteplase has been shown to be a little more effective than TPA in terms of patients with large vessel occlusion, especially the ones who will be going on for thrombectomy. So there are attempts to try this on mild stroke with LVO, and LVO with extended time window beyond 4.5 hours. So this is more than just the regular alteplase that we are using. So there are many randomized control trials. I don't want to go into details in all of them, but to let you know that these are the earlier trials comparing tenecteplase with alteplase. And when you look at the functional outcome at 3 months and successful recanalization, both of the outcomes are in favor of tenecteplase. So tenecteplase is probably not maybe superior or at least non-inferior to alteplase that we are using. And early neurological improvement and also excellent outcome is shown here. So there are new studies using tenecteplase beyond the 4.5 hour window. So this is one of the studies, Timeless. Dr. Silaja already mentioned that, and trying to use tenecteplase up to 24 hours. And in the case with large vessel occlusion, and in this study, most of the patients underwent endovascular treatment later on. So the outcome is not that impressive. It's just published recently in the New England Journal. But the results not impressive because everybody goes for endovascular. I think the magnitude of endovascular is much better than IV thrombolysis. So we don't see that much difference. But another study in China, so they did the same thing, looking at the patients with stroke 4.5 to 24 hours, and these patients have LVO and mismatch on imaging, but they don't have access to endovascular treatment. So tenecteplase was compared to aspirin or antiplatelets, and it was found that actually the absence of disability is much more in the tenecteplase group, although there are some more bleedings, like 3/0.8 in the tenecteplase group. So this is the way that we need to think forward, that maybe tenecteplase can be used in selected patients after 4.5 hours and with some benefit. So yeah, for tenecteplase, I think we have studies that show non-inferiority or probably superiority in treatment of acute stroke comparing to the standard alteplase. It's easier to use and better in terms of pre-MT recanalization. For later benefit would be the ones with mild stroke with LVO. The Tempo study didn't show benefit on that. So mild stroke, even though they have LVO, maybe not for tenecteplase. And for LVO in extended time window, maybe the ones who are not going for thrombectomy may be the candidate for the treatment. Talking about the mechanical thrombectomy, so all of you know that this is treatment of choice, and especially those who presented within 6 hour window. We have so many restriction in the past, like NIH needs to be more than 6 aspects, more than 6, more than equal to 6, and time to groin puncture should be less than 6 hours. And they need to, of course, have large vessel occlusion. So this is a kind of old standard. We depend a lot on the aspect score, where we look at the CT scan or diffusion imaging and look for the abnormality. So the total score would be 10. And if there's some changes in the brain, we would deduct the number. So the lower the score means that there are some more changes in the brain. So this is an example of a case, simple case, 5 hours before arrival, having a stroke and MCA occlusion. This is a good candidate for thrombectomy for sure, no matter what. Extension to 6 up to 24 hours. There are many data on that. So in the guidelines, it's mentioned that after 6 hours up to 24 hours, there are studies using tissue clock. Right, in the diffused 3 and dawn study, the time window can be up to 16 or 24 hours up to the studies. And they use the tissue clock looking for the mismatch and LVO to treat these patients. And it was found in both studies that treating with thrombectomy is beneficial in these cases. So this is already old. Example of a case, 8 hours after stroke, MCA, ICA occlusion, and mismatch on imaging. This is rapid again. And of course, thrombectomy was done. So we have the series of studies going for IV thrombolysis and thrombectomy. And now we are in the era of mechanical thrombectomy in a different type of patients. This is the large core infarction. I mentioned aspect before. The lower number aspect means that there are some changes on CT scan. And we are normally afraid of doing harm in these patients. Maybe we give IV thrombolysis, maybe we do thrombectomy and cause more hemorrhage. And now people are eager to do more. So they are doing mechanical thrombectomy in patients with large core. And also beyond 24 hours, and also the basilar. And they are looking at the smaller type of vessel. In the past, we do a mechanical thrombectomy in internal carotid or MCA M1 occlusion, mainly. But now we are looking at a smaller vessel, which is called MEVO, or medium-sized vessel. I don't have more data on that, but just want to emphasize on the large core patients. So there was a big news a year ago that endovascular therapy works in patients even though they have abnormalities or changes in the CT scan. And there are many studies published recently. Just want to highlight some of them. And this is the Rescue Japan limit, which was done in Japan. And they're having patients with aspect between 3 to 5 and within 6 hours, and another group 6 to 24 hours. And it was found that in this group of patients, even though the aspect is low, still you can benefit from endovascular treatment in this group, although there's a risk of hemorrhage a little more in the treatment group. Another study that I just want to highlight is SELECT-2 study. Again, they're using thrombectomy in patients who have aspect of 3 to 5 within 24 hours. Think about a patient coming within 24 hours and they have changes on CT. Aspect is low. The mean aspect is around 4. So they don't need any imaging of the penumbra. They just do thrombectomy. And it was found that patients who were treated with endovascular did better in terms of the outcome and a long-term outcome than the ones who did not receive thrombectomy. And the bleeding is not increased in this study. So there are many studies on large core during the past year, and so this is the meta-analysis showing that even though the patient is having large core, not down to 2, I would think, a 3 to 5 aspect score, they still can benefit from endovascular treatment. So this is a trend of the treatment right now, and you don't even need to do perfusion or penumbra imaging in some cases. So lastly, I just want to say some words on basilar stroke, which is not in the large randomized control trials in the past, but we do that all the time. This is a patient with basilar occlusion. And since then, there are many studies using thrombectomy and collected the case with basilar occlusion. And in this summary, it shows that we can benefit from endovascular treatment in patients with basilar occlusion. I think it's very clear in my mind that we do that all the time. So IMT can be done in basilar disease, and there's evidence there. So in conclusion, I talked to you today just trying to summarize the new trials on acute stroke management, focusing on the reperfusion therapy, thrombolysis, and mechanical thrombectomy. And for that, I thank you very much.